Thank you all, and thank you for coming. It's lovely to be here. So I'm going to talk to you about the sepsis guidelines, and I'm a retired paediatrician from sunny Leicester. I've been there for 30 years. Any Coventry fans in the audience? Congratulations, well done. Going to put £5 on you guys to win the Premier League next season, because we're certainly not going to. I worked in Leicester and did bits for NICE as a committee member and a guideline chair for about 20 years. Then finally hung up my stethoscope, gave up clinical practice and retired and went to work for NICE 4 days a week as a clinical advisor. I've been for nearly 4.5 years. I'm also the SRO for patient safety at NICE, and so I deal with a lot of questions about sepsis and about the safety of our guidance. So I'm going to talk to you about, I'm going to talk to you about NICE first of all, sorry. This is the advertorial. So we have about 300 guidelines, 20,000 recommendations within our portfolio, so quite a lot to keep up to date in various subjects. We try and focus on what matters most by prioritising subjects that are both of interest to our stakeholders, that both perhaps have a bit of uncertainty about how they're provided, either provided different in parts of the country or no one's quite sure the right thing to do, but also where there's evidence upon which we can hang our hat. That's a really important point. We try not to make, or we can't really make guidance in evidence-free zones as much as we'd sometimes like to. We provide a rigorous and independent assessment based on a clear methodology that's transparent and open for all to see. And we do try and use that to encourage best practice for everyone. We approve or recommend about 100 technologies a year and update or write about 30 or 40 guidelines every year. But I am here to talk about the sepsis guidelines and NICE. This is the slide I thought I was at. And I'm going to talk mainly about a story of our guidelines throughout the year. It's a story without an ending at the moment. It's still a work in progress, and I'll run you through it. And it started about 10 years ago with NG51. And our guidance all got these funny numbers: national guidance, NGs, clinical guidance, CGs, and other such things. NG51, published in July of 2016, covered all ages. It covered all healthcare settings for both community, general practice, hospital, mental health settings as well, and all populations. So its scope included, as you see there, early assessment and recognition, the use of scores that we'll come to later on, a bit about blood markers for predicting and detecting, not so much for duration, but certainly for predicting and detecting. An initial treatment plan, what to do in response to these markers or this early assessment, how to escalate care, but also a little bit about source control, a little bit about monitoring people with sepsis, and some more about information for both people and carers, and a little bit on training education. But I'm going to be focusing this talk about the recognition and early assessment and the use of early warning scores. NG51 early assessment was based on the presence of physiological derangements, a number of changes in areas like respiratory rate, heart rate, temperature, blood pressure, etc., etc. And we looked at those and categorised them to high risk and moderate to high risk, or and normal, and the algorithm had interventions depending upon if you had one high risk or one or two moderate to low risk, what have you. And that was rather usurped by the new score that was, I'll talk about it in a second, that came in 2017 or so. And we changed our guidance in 2024 to incorporate news. And it was really quite unsatisfactory, because news at times only recommended for acute hospital settings and acute mental health settings, and there was some resistance to its use in the community. So the next thing we did was people said, well, there's news, and it was a bit messy because you've got news for adults in acute, you've got criteria based on the traffic light system for adults in community, then you've got ladies or people who are pregnant or have recently been pregnant, and they have a sort of a different criteria based. And then you've got children, and the sort of PEWS is being used, but it's not recommended by us. So anyway, what we did, we split the guidance, or we're in the process of splitting the guidance now, to be age-specific. So there is one for grown-ups, one for children, and one for people who have recently been pregnant. Good. So just a little bit about news before I go any further. Developed by the RCP in 2012, updated in 2017 to News 2, which is the one we use now. And to some extent, NICE was bounced into it by the fact that it was recommended for use in the acute settings by NHS England. And so, although, to be fair, there wasn't an awful lot of evidence for its use or its utility at the time, I think everyone was using it, so it made sense for us to use it as well. It was a real difficulty having NICE saying use this traffic light system, and NHS England and the RCP and the Academy saying it used News 2. So it was a pragmatic decision more than anything else. However, there was some resistance to News 2's use in general practice, with the RCGP saying that more research evidence was needed in its use in primary care setting, and some concerns from GPs about the time it would take for them to assess these patients. So the initial 2024 update to NG51 was driven by the NHS adoption of News 2. However, we wanted to move forward and on from that, and so splitting the guideline into three. NG253 is the adult version of the sepsis guideline. And it covers the same areas NG51 did, but only in people aged 16 and over. It recommends the use News 2 in acute health settings, in acute mental health settings, and in the ambulance. But recommended, or said we should consider using an early warning system, but didn't say which one. Real fudge in community settings, largely because of the objections from the Royal Colleges, and because there wasn't actually good evidence of News 2's utility in the community at the time. So initial assessment still based on examination of the patient, taking vital signs, and noticing deviation from the normal, which is what News does as well. News has 7 criteria upon which you look at the deviation. Our traffic light system has criteria and you notice the deviation. So they are actually very similar. So it's still not great, I think. And I think that over time, this is my opinion, things will move on because you've got the GP who sees the patient in their home, calls the ambulance, and the ambulance will say, well, what's the News score? And when the paramedic arrives, they're not going to say, well, I'm in the patient's home, I'm going to use criteria-based traffic light system, but once I get in the ambulance, the patient, I can do News. It's just, life isn't like that. So I think there will be a move towards using News 2 more widely, and I think that's why we said the recommendation was to consider using an early warning score in people with suspected sepsis in community. The other thing to mention is the guideline at this stage is about people with suspected sepsis. And I think coroners, lawyers, have said to me in the past, well, you didn't follow the NICE guideline. And if you look at the history, that's because they didn't suspect sepsis. And I'll come back to this towards at the end of the talk, that the guideline applies at this stage to people with suspected sepsis, but you have to suspect sepsis to get there. Let me just go on a bit more about NG253. There are other changes that we've brought into it, and these were looking at blood tests, primarily procalcitonin and CRP, and you'll hear more about procalcitonin later on today. Freddie had a good talk about duration, but also we were looking specifically about identification of sepsis. Blood lactate, so this is a marker of deterioration. Is blood lactate useful to identify worsening sepsis? Serum creatinine, kidney injury, how does that work in sepsis and deterioration? And also, people with sepsis who come into the ED or go to the GP, when do you refer them upwards? What are the criteria for getting people involved? And particularly in the hospital setting, who should you involve? And we talk about clinicians with prescribing ability. We talk about clinicians senior clinicians at ST3 or 4 or above. I thought I turned it off, sorry. That's the time to take my antihypertensives. Anyway, I do apologise. So clinicians at ST4 and above, we talk about senior clinicians, consultants and intensivists, and we try and talk about when's the most appropriate time to get those. So the amended recommendations on communicating with people and managing sepsis acute health setting are part of that. So that's a really quick run through the new NG253. NG254, due to publish in February next year. It's just started to be in progress now, the updates of that. At the moment, it's just the paediatric bits of NG51 taken out and put into a new guideline. But we're going to look at similar things. So first of all, pews, moving from the criteria-based traffic light system to pews, or new pews, and how that will work. Interesting. Largely evidence-free zone in terms of evidence that NICE would normally use. Lots of experience, though, which I think will inform us well with that. And then also looking at procalcitonin, IV fluids, how much, how often, when to give more. Again, lactate, primarily for organ hyperperfusion, and the use of peripheral vasopressors in paediatrics. Largely looking at safety and rather than efficacy. And then NG255, pregnant ladies, very similar, replacing the criteria-based triggers with mews or meows, whichever one it is. Again, probably less evidence there, but I think pragmatically we're going to look at how it's used and how well it works. And then again, the same number of additional areas, procalcitonin for predicting sepsis, IV fluids, how much and how often, lactate and peripheral vasopressors. There are, of course, issues around early warning scores, which we'll all be aware of, that I think will affect the implementation of these 3 different guidelines. Primary care, I've mentioned, primary care and use of news, I think I've talked about already. News and pews in ED, particularly for those areas that don't have a separate paediatric ED. If you're a staff nurse in the ED that sees both, will you be used to using pews and news? Will that cause problems? They're different. Will the triggers be different? You're going to have a very different educational program for them. So that's the point. If you've got a 15-year-old who's pregnant, do you use mews or do you use pews? I suspect you use mews because I think the physiological derangement from being pregnant is probably greater than from being 15 rather than 16. So there is that issue. If you use multiple scores in one department, how does that work? I think that's a real problem with implementation. And then there's a transition, which is a huge problem in paediatrics anyway. For someone who's 15 years, 264 days, get their pews, they go to the ward the next day, they're on news. How does that work? How do you marry them together? How do you look at progress? Just some personal reflections from me, and this isn't nice to speak now, this is me as an intensivist. You know, collecting a score is not a therapeutic action. It makes no difference. And in my work as patient safety, in my work as I used to advise the Ombudsman, you've seen people where they've documented beautifully these changes and haven't done anything. The trend's important. The score is less so. The trend is much more important. And this is a quote from my good friend, Professor Damien Rowland, who's an ED consultant in Leicester. When it becomes about the score, it's no longer about the child. And we had a long discussion with a centre where they were saying, well, if it's 3 and you've got this, or should it be 4? And, you know, the minutiae of is it a 3 or is it a 4 is probably less important than looking at the patient. We're going to hear a bit about Martha's rule later on today. Listen to the patient, listen to the parents. Is this normal for them? Is this behaviour normal for them? I think that's very important. And the final point, of course, is that news, pews, mews aren't sepsis specific. They say something's wrong. And if you've got a high score or an escalating score, it just says, think, what could this be? Of course, you've got to think, could this be sepsis? Because sepsis is horrible and kills you. But it could be other things. And so it's about thinking. So in summary, I want to talk to you and say that NICE guidance has been amended to include news in acute and mental health settings for adults. We are also looking at reviewing the evidence in other areas, such as indicators of hyperfusion, how much fluid to give, use of procalcitonin, etc., etc. And we are doing separate reviews on the under-16s and on people who are or have recently been pregnant, and those should publish in 2027.